thank you so much for inviting us to present today at the Association of Food and Drug Officials Conference. My name is Hope White. I am the Roanoke City and Allegheny Health District's district epidemiologist, and I am here today with Cindy McDowell, the Roanoke City and Allegheny Health District's environmental health manager, and Paula Bittinger, the Roanoke City and Allegheny Health District's standardization officer. And today we will be presenting on a deadly hepatitis A outbreak in a local restaurant chain. Hepatitis A is a highly infectious viral disease. It is fecal-oral transmission. The incubation period is between 15 and 50 days. However, the average is approximately 4 weeks. It is vaccine preventable. Some of the symptoms include fatigue, poor appetite, fever, nausea, vomiting, dark urine, and jaundice. And persons infected are typically contagious from 2 weeks before symptom onset date until approximately 1 week after jaundice onset. In this slide, we wanted to show the state-reported hepatitis A outbreak cases as of November the 26th, 2021. Of importance with this slide, you will notice that all of the surrounding states surrounding Virginia have had high incidence of hepatitis A. And on this slide, we wanted to show the hepatitis A investigation summary report, which shows the cases of hepatitis A in Virginia from January the 1st, 2019 through July the 22nd, 2021. This slide is a little dated in that we currently have 4 deaths associated with the outbreak that we are discussing today. So just keep that in mind as you view this slide. As I mentioned earlier, hepatitis A is vaccine preventable. It is a 2-dose series. It is recommended for all children at age 1 year. It is also recommended for persons at high risk for infection, as well as persons at high risk for complications if infected. Now, a little bit on the background pertaining to this specific outbreak. So between September the 17th through the 20th, 2021, there were 3 cases of acute hepatitis virus reported to the local health department. Routine follow-up was conducted per the Disease Control Manual, or DCM, which included investigations. And at that time, no commonalities were identified during the initial interviews. Then on September the 22nd, 2 additional acute hepatitis A cases were reported to the local health department. Routine follow-up was conducted once again per the DCM. The investigations conducted revealed this time a commonality of eating at a local restaurant chain, otherwise known as Restaurant X. The investigations also revealed there was a positive hepatitis A food handler at Restaurant X. Background continued. Between September the 23rd and 24th, 2021, 4 additional hepatitis A cases were reported to the local health department. And at that time, the investigation revealed that the hepatitis A positive food handler, or the index case patient, that patient's onset was August the 25th, 2021, while at work at Restaurant X. The index case patient's last day worked was August the 26th. Therefore, Restaurant X exposure period was August the 10th through the 26th, 2021. At that time, an environmental health investigation was conducted and discovered that the ill food handler had worked at 3 out of the 7 restaurant locations. Then between September the 27th through 30th, 20 additional hepatitis A cases were reported to the local health department. And during that same time frame, we were able to secure 9 of the case patient specimens, and we sent those to our state laboratory, the Division of Consolidated Laboratory Services, for whole genome sequencing testing to look to see if these isolates were indeed a genetic match. The outbreak case definition included for a confirmed case patient that entailed a patient with a discrete onset of symptoms and jaundice or elevated serum aminotransferase levels, or ALT, and who would have tested positive for hepatitis A, IgM, and frequented any of the 3 Restaurant X locations, or was a close contact to the index case patient during the dates of August the 10th through the 26th, 2021. A probable case definition really mimicked a confirmed case definition, except it excluded having been tested for an elevated ALT level. And here you will see the epi curve, which shows the confirmed total and probable cases of hepatitis A by date of illness onset for Restaurant X through August 2021. From August 2021 through October 2021, we had a total of 51 cases, which did include close contacts of the index case patient, whereby there were 3, as well as secondary cases whereby there were 2. And on this slide, we wanted to show the age demographics of the case patients. You will notice that the majority of the case patients were in an older demographic. And we think that that is because the restaurant chain had been in the local area, established in the local area for many years. And many of the patrons were of the older generation. As I explained earlier, the whole genome sequencing results, we were able to have 9 specimens tested to see if they were genetically related. And it was determined through testing that 8 out of the 9 specimens were genetically linked, which did let us know that these cases were definitely associated with each other genetically. And now I will turn it over to Cindy McDowell.
Thanks, Hope. I'm going to start by giving you a little more insight into the timeline for the outbreak. On September 23rd, our epidemiologist notified the health director of a possible connection between some of the positive Hep A patients and 2 locations of one of our local restaurant chains. The director then notified the environmental health manager, who arranged for staff to immediately visit the 2 implicated locations. During these visits, environmental health staff interviewed the manager on duty and evaluated the personal hygiene practices that the restaurant had in place. Managers were also asked about any recent employee illnesses. The EH manager was able to contact the vice president of operations for the restaurant chain and asked for a list of employees who had worked at both locations since August 1st. At this time, we did not have a name of any positive Hep A patients who worked at either of these locations. By the next day, September 24th, the epidemiologist had been able to verify that one of the positive Hep A patients was a food worker for this restaurant chain. When we looked at the employee list provided by the VP of Operations, we found that this employee was on the list of employees that had worked at multiple locations. The health director quickly arranged a virtual meeting with the EPI team at the regional and state level to discuss the outbreak. We felt like we had sufficient evidence to link the infected food worker to the outbreak, and the next step would be to immediately inform the public after obtaining the specific dates and locations that the employee worked. After some encouragement, the infected employee notified the restaurant of their Hep A positive status, and the EH manager was then able to quickly obtain the dates and locations that this employee worked. A press release was put together and shared with the VP of Operations of the restaurant chain before being released to the public later that afternoon. So this is the press release that we sent out. It stated that an employee that worked at 3 of the locations of the restaurant chain was diagnosed with Hep A and that anyone who ate at one of these locations from August 10th through August 26th may have been exposed. The alert listed symptoms of Hep A and asked people to seek medical care if they developed any of these symptoms. So then around August 7th, we had an environmental health staff member who performed a second environmental assessment of 2 of the locations and also interviewed the vice president of operations. The 3rd location had already been permanently closed for several weeks. Our EH staff member provided education and resources for Hep A, including offering Hep A vaccine to restaurant staff. The epidemiologist completed a NORS report, and unfortunately, we had our first death related to the outbreak. 3 additional deaths occurred between October 24th and October 26th. And it wasn't until November 20th that the outbreak was officially declared over, with no more reports of primary or secondary Hep A cases. Some of the challenges we faced included the fact that Hep A has such a long incubation time, from 15 to 50 days. The infected worker last worked on August 26th, but we had no indication the outbreak was linked to the restaurant chain until September 23rd, almost 4 weeks later. This put us out of the 2-week recommended window for post-exposure vaccine, but it was offered to close contacts anyway. Since a long time had passed, no food was available to sample. For Hep A, the contagious period begins about 2 weeks before symptoms appear, so proper personal hygiene is critical to preventing the spread of Hep A, and the restaurant needs to have policies already in place and make sure employees follow these policies for Hep A to be prevented. So while this was a very stressful situation for our health department staff, everyone involved rose to the occasion. Our district epidemiologist worked tirelessly interviewing positive patients and quickly recognized the possible link to 2 locations of one of our local restaurant chains. Her persistence also led to the quick identification of a positive food worker linked to these locations. EH was able to then quickly get the positive worker schedule so a press release could be put together to warn the public. Our press release went out the same day we made the connection between the positive worker and the restaurant chain. As mentioned earlier, our epidemiologist completed a NORS report around October 7th. For anyone not familiar with NORS, it stands for National Outbreak Reporting System, and it is a web-based platform used by local and state health departments to report all waterborne, foodborne, and enteric disease outbreaks to the CDC. This slide illustrates the steps that transpire between an exposure to a pathogen, to identifying an outbreak, to reporting it to the CDC. I will now turn the presentation over to Paula Bittinger.
Thank you, Cindy. So the final environmental health contribution to this outbreak was to report our environmental assessment data in NEARS. This acronym is for National Environmental Assessment Reporting System. It is an environmental health surveillance system that enables ongoing systematic collection, management, analysis, interpretation, and dissemination of foodborne illness outbreak environmental assessment data. For part 1 of NEARS, the general characterization of outbreak, it was reported to NEARS that there were 3 locations with exposures, with 1 location permanently closed prior to outbreak investigation. No environmental assessments were performed at this location. The confirmed primary organism was hepatitis A. There were no specific ingredient or multi-ingredient foods suspected or confirmed in the outbreak. The activities conducted during the outbreak investigation to identify contributing factors included environmental health interviews with establishment managers during the initial environmental assessments, and an interview with the vice president of operations during the second environmental health assessment. During both environmental assessments, general food practices were observed. The epidemiology team interviewed case patients and coordinated the collection of clinical samples. The only control measures available for this outbreak was public notification via the public health alert to media by our district health director, Dr. Cynthia Morrow. For part 2, establishment categorization and review, It was reported that all three locations had a complex process flow of cooking, cooling, and reheating. All locations are high volume with prepared food held over for only a few days, and there's no freezing of prepared food. Therefore, no potential for future exposure from contaminated food. In reviewing the last routine inspection reports, all three locations had one critical violation during the last routine inspection of cold holding. This would not have been a contributing factor for this particular outbreak. There were no personal hygiene violations during the last routine inspection for all locations. In reviewing the menus, no undercooked oysters are served, which can be a potential source of hepatitis A. No environmental samples were taken due to the time from exposure to initial outbreak investigation, 4 weeks. Also, due to COVID-19, all locations had cleaning and disinfecting protocols in place for non-food contact surfaces. For part 3, manager interview, the vice president of operations was interviewed for both locations. Kitchen managers all have food safety certification. Food workers and managers speak English fluently, therefore no communication concerns. Food workers receive on-the-job food safety training. All locations have a written cleaning policy, written glove use policy, and they have a written vomiting and diarrheal response procedure and a written employee health policy. Sick leave is provided for managers, but not for food workers. Report 5, establishment observation. During both environmental assessments, it was observed that hand sinks are available with warm water, soap, and drying towels. There was no bare hand contact with ready-to-eat food observed. Disposable gloves were available for all food handlers. The food contact chemical sanitizer was at proper concentration, as well as the mechanical warewashing machine sanitizer. An employee health reminder was posted for employees, and a certified food protection manager was present at all locations. For both part 5, suspected foods, and part 6, positive samples, these were not applicable to our outbreak investigation. Food and environmental samples were not taken due to the length of time between exposure and investigation. For part 7, contributing factors, it was determined that the environmental antecedent was insufficient staffing due to the COVID-19 pandemic. Many food facilities in our health district were impacted by the challenges of employees leaving employment and hiring new employees. As a result of short staffing, the index case patient food handler was performing multiple duties and working at multiple locations. For this outbreak, the primary contributing factor was determined to be C10, bare hand contact by an infectious food handler, resulting in a hepatitis A outbreak. The health district's response was to notify the public of the situation, including location of the exposures, potential exposure dates. We provided public education on signs and symptoms of hepatitis A and recommended the public seek medical attention if they had symptoms and met exposure criteria. Vaccine clinics were held at both locations for employees, although there was less than optimal uptake. And hepatitis A vaccines were offered at the Roanoke City Health District and for any member of the public, as well as on off-site locations. Lessons learned from this outbreak was the importance of relationships. You need to be a team of teams for an optimal response to any foodborne outbreak. At the local health district, this included environmental health team, epi team, communications team, nursing team, and the leadership team. At the regional level, we had an epi team and a communications team. And at the central level, environmental health team and epi team, which included a policy team to help with the Freedom of Information Act requests received by our local health districts, of which there were many. Throughout the outbreak, much attention was given to communication with leadership at the food establishment and with local, regional, and central offices. The Environmental Health Department had an excellent relationship with the establishment's managers prior to this, which developed trust between the managers and owners and the outbreak team. Transparent communication with the public was essential. Recommendations from this outbreak includes reassessing current vaccine recommendations. We strongly believe there needs to be a recommendation for a routine hepatitis A vaccination for food workers. Food handlers are at increased risk of becoming infected. This is based on recent studies and demographics, and are at increased risk of transmitting it based on occupation. We need to continue to work with food establishments to expand knowledge of the risks of hepatitis A and the multiple layers of opportunities to prevent the transmission of hepatitis A within food establishments. Good personal hygiene, no bare hand contact with ready-to-eat food, and hepatitis A vaccinations. At this time, we would like to acknowledge at the local health district, Dr. Cynthia Morrow, our health director, Cindy McDowell, our environmental health manager, Mary Kate Bowser, our RN manager, Jerry Ann West, immunization RN supervisor. And at the state level, Virginia Department of Health, Paige Boardwine, regional epidemiologist, Dr. Lauren Turner with the Division of Consolidated Laboratories. We appreciate APTO's invitation to present our hepatitis A outbreak findings at this conference, and we hope you have found it informative and interesting. Thank you.